definitions and implementation I'm finding across the literature, and so and the more people I talk to, I get different broader perspectives about what this really means, or how these DNR orders are implemented at their particular hospitals or their clinics. So there's a lot of variability. So if you've got experiences to share and you can educate me on this process, that would be great, because I feel like I have not conquered this topic at all yet. So no disclosures. Here are our learning objectives. I want to distinguish between the various descriptions of medical care preferences and medical care intensity. Understand the patient and hospital level characteristics that are associated with DNR, do not resuscitate orders, and then the particular analysis I'll show you is the relationship between DNR orders and quality of care and outcomes in US veterans. So the context, you'll all be pretty familiar with this. Health organisations and policymakers are faced with this constant struggle of the need to improve quality while controlling costs. Policymakers desperately need practical and valid measures of quality of care. Mortality is well recognised as a very poor indicator of quality of care, but unfortunately mortality is readily measured. And that means we're going to use mortality because it's one of the things that we can measure. And here's an example from CMS, Centers for Medicaid and Medicare Services in the United States, the RAC-DePoo program. As horrible as it sounds, it's almost as horrible to actually implement and respond to. It's the reporting hospital quality data for annual payment update. Basically, this is CMS's pay for reporting incentive program. Hasn't gone to pay for performance yet, but the implications are after we pay you for pay for reporting, the next step in the arms race is probably pay for performance. For stroke, they have introduced, this was originally going to be in 2011, it's now 2013. There's lots of controversy about this, but it basically comes down that they give hospitals, or will give hospitals, a 2% bonus on top of the total Medicare reimbursement rates if hospitals meet satisfactory standards for reporting of risk-adjusted 30-day mortality and risk-adjusted 30-day readmission rates. And these are all already being used for other conditions, particularly pneumonia, AMI and CHF. You can actually go to this hospital compare website, plug in your zip code or area, compare hospitals, both in terms of their structure and processes, and also these outcomes. Yes?
Is that 2% of the total CMS reimbursement, or is it 2% of the total for the stroke patients?
For the stroke DRG payments, yeah. So that's happening, and lots of controversy around it. And so if we're going to use mortality as a measure of hospital quality, then it seems to me that we should really have a better understanding of the following facts. So what are the causes? What causes hospitalized stroke patients to die? There's actually very little data on this. And how much of that mortality is truly preventable? And then how much of this mortality is preference-based? Particularly in the area of stroke, being as it primarily affects elderly populations. We all know from the quality of life literature that people actually rate severe stroke as a classic case of a situation worse than death, that your patient utilities for being bedridden and basically have no function is worse than death. So there is a very real case to be made that in some cases, some stroke cases, that death actually may be a preferable outcome, and so we can't always regard death as avoidable and necessarily the outcome to be prevented. And also, how do hospital practices, whether it's related to admission policies, patient-shared decision-making, policies related to hospital transfer, policies related to hospice discharge, policies related to chart documentation, how do all those things impact mortality? And then the implication of all of that is, well, is the potential for gaming of the system once we set up a true mortality incentive program. So it's pretty easy to think about if you really wanted to lower your mortality, don't take severe transfer patients, so stop seeing these intracerebral hemorrhages. Depending on how these calculations are made, You know, early discharge to hospice may be a good thing. There's lots of ways that these mortality statistics could be manipulated. Could be. We're not saying it happens. So let's talk about DNR orders themselves. Do not resuscitate orders are supposed to represent patient and family preferences for limitations in cardiopulmonary resuscitation and are not intended to limit other aspects of medical care. That's the official definition. DNR orders are obviously common, especially in elderly patients and those with severe acute medical conditions, such as stroke. Most patients who die in the hospital shortly thereafter have some notation of either DNR orders or other limitations of care. The vast majority do. In other words, in-hospital mortality or mortality shortly after discharge is actually a very highly predictable event because most patients have some notation of impending quote-unquote doom. And the timing of DNR orders relative to admission is very important. So the later that the DNR order is documented, the worse the prognosis of the patient. This makes sense. Early DNR orders can be perhaps nothing more than advanced living wills, the recognition that this patient doesn't want DNR orders should they succumb to a cardiac arrest, whereas DNR orders posted 5, 6, 7 days into care can often be reflective of treatment failure, severe complications, etc., etc. Okay, and here's just one particular study showing this, Cleveland area study of 13,000 stroke patients in 30 hospitals back in the early 1990s, showing hospital mortality rates increasing linearly with the time at which the DNR order was first written. So these DNR orders represent a really interesting mix of different phenomena. In other words, treatment failure all the way to simply advanced directives or preferences, pre-admission preferences in care. So, although DNR orders are not intended to limit medical care beyond resuscitation, several studies have shown that stroke patients with DNR receive less aggressive treatment and poorer quality of care. So, a case from the Midlands area in the UK, DNR patients who are less likely to be admitted to a stroke unit, see a stroke team, undergo brain imaging or receive aspirin. You know, both of those things are really essential components of care. So the question is, why would DNR patients be treated differently from those? And particularly in the area of hemorrhagic stroke, there's a lot of concern about DNR orders being early DNR orders leading on to a self-fulfilling prophecy of demise of the patient. So there's an active area of research and discussion, particularly in the area of hemorrhagic stroke.
Just one question. I mean, the way you're framing this is that DNR is supposed to just limit cardiopulmonary resuscitation. I guess that's based on a definition somewhere. Yeah, that's based on a definition, but obviously the practical implication that it means a lot more. I mean, it can mean a lot more. Yeah, I would say in my experience, it generally means limitations on what you call aggressive care. So that would go well beyond CPR into things like, you know, the use of central lines, inotropes, advanced testing, a whole range of interventions, which I think is within the realm of what is meant by DNR. So it may not meet that definition, but it's certainly within the common practice how it's applied. So, you know, it kind of gets into the whole issue of quality. I mean, quality care may be not, higher quality care may in fact be not putting the patient to a CT scanner when it's not going to actually influence outcome and, you know, just cause disturbance to the patient and family and so on. So I just want to no, your point is well taken, and we'll basically get to that point in a minute. That what is the true meaning of the DNR, and what's the context of its used, and particularly in the past literature on DNR, the papers coming out in the 80s and 90s, it was simply just DNR and everything associated with it. Now in the more recent literature, we are making distinctions between DNR and other palliative care measures or comfort measures, so getting a little bit more specificity in the language, which I think is really important. And then you can imagine from your clinical experience how your interpretation of DNR might differ from somebody else's, both within your group and obviously across hospitals in other areas. So this is all why I think this is a really interesting and important area. So
So yeah, given the concerns about what the DNR orders actually mean, there's a lot of people have been looking at this issue of like, well, do people inappropriately, and that's always a loaded word, but do people inappropriately interpret DNR orders to limit care beyond what the original intent of the DNR orders? This is actually an extremely difficult, I would almost say impossible thing to prove, because there was no randomized trial data of DNR orders. It's all observational data. DNR orders themselves, if you prevent someone from getting, a code blue, would be expected to contribute to an increased mortality. But the vast majority of the increase in mortality amongst DNR patients is because of all of these other characteristics and prognostic factors and comorbidities that came along with the DNR. So it's pretty much impossible to disentangle the two. But people have tried, and again, this Shepherdson group from Cleveland did a very nice, really one of the best examples, practical examples of propensity score analyses. This is pre-Peter Austin era, back in 1999, but still, it was a pretty good paper, where they tried to adjust for all those factors associated with DNR, including DNR propensity, age, admission severity, intracerebral hemorrhage, coma, severity of symptoms of admission. And they basically, not surprisingly perhaps, showed that DNR orders were highly associated with in-hospital mortality. So any DNR, even after adjusting for the propensity and everything else, was associated with an odds ratio of 34. And even a DNR on the first day, which are most likely to represent pre-event limitations, patient preferences on care, were associated with an increased mortality of 2.4 odds ratio. So, these, and they also found that the increase in mortality associated with DNR was the greatest amongst the propensity groups that had the least risk of being DNR patients. So the very healthiest patients, if they had a DNR, actually had the highest increase in risk, comparing DNR to non-DNR patients. So all of this was interpreted as being evidence perhaps of inappropriate care, and all these papers say, well, we need much better data about what do these DNR orders mean and how they're interpreted, and this is now 13 years ago and I still haven't seen that. I still haven't seen that stuff. So, as we've already discussed, DNR orders or limitations in care can represent a constellation of complex factors. These advanced directives or the living wills that your lawyer has you do, your pre-admission function, the actual acute illness severity of the condition that led you to the hospital, treatment failure, perceived futility, complications, perceived futility of treatment and resuscitation, patient and family beliefs and values, as well as physician community and hospital practices. So you throw all that into the mix, and basically DNRs can mean almost anything to anybody, depending on what the context is. And so this is where it gets to important about the labels and definitions. So all of these things on this slide, to my mind, can be conflagrated together. So you've got these advanced directives or living wills, which really should be separated from do not resuscitate orders, or do not intubate orders, or no code, no CPR, no resuscitation. So there's this group of sort of classic DNR. And then there's all this other stuff that should or should not come along with the DNR, which is identification of what we call comfort measures, end-of-life care, hospice care, palliative care, terminal care. And it's this distinction between the three of these different camps is, I think, really important, and is not always clear in the literature about, well, were the DNR orders back in the UK in the early 90s, were they really just their label for this, for palliative care? If it wasn't articulated well in the paper that these DNR orders may have different interpretations. Okay? And we also know, perhaps not surprising, that there's a tremendous variability in the prevalence. I put prevalence in quotes here, because it's really it's also a matter of documentation. There's tremendous variation in DNR orders across hospitals when you look at that. And we also know from studies that the prevalence of DNR to the proportion of patients in the hospital with DNR orders is actually lower in teaching hospitals. It's also been found to be low in hospitals with religious affiliations. And it's also higher in smaller rural hospitals. So this DNR thing, right, is really important in terms of predicting a bad outcome, and yet we have this tremendous variability in hospitals. Some of that, of course, could be explained by case mix, that patient populations do vary. If you've seen a more elderly and sick population, maybe you'd expect a high prevalence, but certainly not the variability that we see in the literature and in the study I'll show you here. So these are standardized differences comparing these are 30 hospitals from Cleveland, comparing their DNR rates to the overall rate in the whole population. So these are relatively under-reporting DNR, and these are relatively over-reporting DNR. But there was widespread variability at the hospital level, anywhere from 12% of patients all the way up to 32% of patients had DNR orders. And so this has been frequently reported. And the other important point about DNR and these limitations of care is how are they handled when we're calculating our performance measures, our quality measures. And so are they or are they not so are patients with DNR orders and comfort measure only or other palliative measures, do you or do you not include them in the denominator for any particular performance measure? And again, you start looking around, and this is sort of something that sort of gets included on the sort of fourth page of the measure definition, and sometimes it's there, sometimes it isn't, and this obviously can have a big impact on your compliance. So whether that's included or not, it seems to me, looking across the Coverdale registries and the Get the Guideline registries and this VA data, there's a lot of variability in terms of how these things are handled. Okay, any questions on that preamble on the importance of DNR?
Just a general question, Matt. A lot of this literature seems to be from the 1990s, and maybe that's the best literature. Or is there a deficiency of literature in the subsequent to that? Was there a vogue for it, and then it's
right? It seemed to get really like a hot topic into the mid to late 90s, and then really not much. A few papers here and there, and the odd editorial. But there's been a real dearth of literature in the last 10 years, so that's actually what I'm finding. Yeah.
Where do you put withdrawal of life support?
Where do I put it?
Is it a DNR?
I don't know. I mean, I think it can be, depending on the documentation practices. I mean,
they often don't write it down, but it's obviously the same.
Comes to the same thing.
Same end.
Yeah, same end. Right. So so I guess it varies, and that's the sort of thing that varies between hospitals. When I talk to physicians about how we handle it, how do we label these things, and whether they are documented or not. Because obviously sometimes these decisions are made between patient or family and physician, and there's a tendency to not want to document those formally down on paper. So, okay, so let's now look at the particular analysis I'm going to do. This is looking at DNR orders, quality of care and outcomes in veterans with acute ischemic stroke. Again, this is my collaborators are mostly from the Indiana Quality Improvement Group at the Rowdenbush Medical Center. And again, what we're going to do here is characterize for ischemic stroke. So we're on looking at ischemic stroke patients, veterans in the VHA who had DNR orders, and assess the relationship between DNR and the quality of stroke care and outcomes in this project. So the VHA OQP Query Stroke Project is a classic system-wide stroke collaborative quality improvement project where they wanted to assess the quality of care for veterans with acute ischemic stroke, and then obviously improve the quality of care once you've got this baseline data. The baseline data was 5,000 veterans admitted to 131 different Veterans Administration medical centers with a primary discharge code of ischemic stroke. And then they sampled all patients, all veterans who went to these smaller hospitals, defined as less than 55 strokes a year, and an 80% sample of these larger facilities who saw more than 55 strokes a year. And we excluded TIA, elective admissions, in-hospital strokes, and patients with missing data. So we lost about 1,000. So we ended up with a final sample of 3,965 veterans with ischemic stroke. The data was retrospective chart review, the design, using trained abstractors from the West Virginia Medical Institute, who are trained and do a lot of these chart abstractions of the VA. They use electronic medical records, so they basically sit in Morgantown, West Virginia, and abstract the data without ever having to go to these 131 institutions. So no paper records were used. We abstracted all the standard data that you would expect us to be interested in: demographics, comorbidities, a measure of stroke severity, the NIH stroke scale, vital signs, medications, etc., etc.
Matt, for clarification,
Yeah.
are they able to actually get into the medical records and multiple hospitals from a remote site?
But it's all under the VH.
It's under VHA
system. Yeah.
And their one ethics committee approved that? Is that?
Yeah, I believe so. Yeah, I think it's one ethics committee. It's all under the same. It's all under one system.
Yeah.
Yeah.
I mean, that's remarkable.
Yeah. So they have some definite advantages. Occasionally, they come across some definite advantages, and this is one of them. So they can do this thing very efficiently.
How much time does it take for them to abstract one chart?
I don't know that exactly. I mean, I would think, I would think probably like, I wouldn't expect it to be very different from when you have a paper chart in front of you, so I'd think probably half hour or something like that. I don't know, I could find out. And then the data abstraction pilot test was good. 90% of the items had high CAPAs, inter-rater reliability greater than 70%. So, DNR orders in the VA are an electronic order. So they are documented electronically. If they could not find an electronic order, the abstractors were told to search the notes, the nurse and physician notes for, no code, no CPR, no do not intubate, or no resuscitation. So those DNR orders are generally coded electronically. Comfort measures only, CMO, these palliative care, are not documented in any particular location. So again, the abstractors were told to screen through the notes, looking for labels of comfort measures, end-of-life care, hospice care, palliative care, terminal care. And then we were obviously also interested in the timing of that first DNR or CMO, was when it was recorded. And for the purpose of this data, we made this distinction between 2 days or thereafter. So you either documented on admission or the next day, or 2 days afterwards or later. And again, the inter-rater agreement on DNR and CMO were very good. So part of this project, they got a team of experts together, sat around a table and say, tell us what performance measures the VHA should be using for stroke. They came up with 14 quality indicators, 9 or 10 of which are really standard quality indicators that everybody uses, including the registry here, the Canadian Stroke Registry. And so these are broken down into early hospitalization, thrombolysis, TPA for patients who arrive within 2 hours, dysphagia screening in the emergency department, documentation of the NIH stroke severity scale by hospital day 2. The inpatient indicators included aspirin therapy within 2 days, DVT prophylaxis, early ambulation, which is simply the percent of patients who are ambulatory by the end of hospital day 2. Full risk assessment using something called the Morse 4 scale, and pressure assessment using something called the Braden scale, and then the documentation of rehabilitation FIM, functional independence measure scores, standard assessment for rehabilitation needs. And then the discharge-related indicators are medication relays, antithrombotics, atrial fib, warfarin and atrial fib, lipid management, smoking cessation, and then stroke education. So those are pretty standard measures. In terms of our calculation of these quality indicators, DNR was not used in exclusion in any of those. However, CMO was an exclusion on 10 of the 14 measures. So if you were comfort measures only, particularly on the discharge-related measures, some of the later measures in the hospital period, if you had CMO, you were removed from the denominator. So we calculated the performance or the compliance with each one of these 14 measures.
Why would you differentiate in CMO? And are you asserting that patients given a comfort measures only order are somewhat different from those given the DNR order?
Yeah.
And do you have evidence to back that up, that in the VA system these orders are used?
Yeah, I think because the DNR is an electronic order, and I mean across 131 facilities, I think there's probably a variability in how that's handled. But if you look at the actual, the measures definitions, when these were put together, I mean, they were excluding the CMO patients from most of these measures, but not DNR. So the implication is that I guess policy-wise.
To stop you there, so when these quality indicators are being developed, you're saying that they said comfort measures only patients should not, these don't apply, but they do apply to DNR. You're saying that was explicitly said they do apply to DNR?
Yeah.
I'm astonished at that.
Well, it goes back to that. It goes back to what you believe the true definition of DNR is, and so DNR is
they have
just
very much a different.
Yeah. So this is good because I think it points to the fact that this is kind of a mess, in my opinion. So and I wasn't there at the time that they made these explicit decisions, but this is pretty common. I mean, given the guidelines, we don't exclude DNR patients from our performance measures, but we do. Now we've started to exclude CMO patients. So yeah, this is happening, but I don't know that too many people sit around and really think about the implications of this. So, okay, so we're going to do a statistical analysis. We're going to do general estimating equations, logistic regression to look at the association between DNR status and both performance on each quality indicator and poor outcome. Poor outcome being defined as in-hospital death or discharge to hospice. We're going to adjust for age and race ethnicity, stroke severity, the Charlson Index of comorbidity, burden, and pre-stroke ambulatory status, and we're also going to look at the effect of DNR timing on outcomes. So here's the data then. This is what we found in terms of the prevalence of DNR and CMO. So 535 of these almost 4,000 stroke patients, or 13%, had a DNR order, and 71% of the DNR orders were written on either day 0 or day 1 of admission. Okay. Only 145 patients of 3,965 had CMO documented during their stay. Okay, so just 3.7%. But 139 of the 535 DNR patients were also CMO. So if you're CMO, you're basically DNR. I guess you could say you should all be DNR if you're CMO. I don't know exactly how to explain these 6. Perhaps they're just data documentation of this. But the implication would be if you're CMO, you probably should be DNR. Or the interpretation is you're also DNR. So, 13% overall prevalence of DNR, just shy of 4% prevalence of CMO, and a quarter of the DNR patients were also CMO.
Well, that's really quite a striking finding, I think. I mean, just
which
one
one?
point. Well, the fact that there are DNR positives, but the majority of them don't say comfort measures only. Right. It's getting back to Michael's point that there is a dissociation, and it doesn't look like that's accidental. That's deliberate, but whether it's a cognitive, deliberate process, I'm not sure, but it's quite striking.
No, I mean, so they're trying to make this distinction between the two. The question is, they're doing that in the data abstraction. Is that what people on the floor, on the shop floor, are doing too?
Attention please. We have a cold flu and light ground.
Talking about maybe it's just a dinner.
Just anticipate an obvious question. Did you do any qualitative? Have you done any qualitative research?
No. So this study leads to a lot more questions than it answers. And working the VA, to be honest, is is a little bit of a dance. You just can't walk into the VA and say, hey, I want to do a study that shows that veterans are getting really lousy care and dying early. You know, I got the evidence here. So it's sort of an incremental step. So we're doing this first, and then I want to go back and say, okay, I really think we should look at this especially because of this, right? So this is the plot of the prevalence of DNR orders by 131, actually it's 114 hospitals with at least 10 stroke patients. There's wide variability in the prevalence of DNR orders here across hospitals. 24%, these guys here, didn't document any DNR patients. I mean, I can't believe that there was really no patient in those hospitals that did not have a DNR order.
The death panels are off to the left, aren't they?
What's that?
The death panels on the left.
All the way up to 50-60%, you know, like, well, what's going on here, you know? I'm not sure where I want to be on this continuum, maybe somewhere down here, but I'm not sure I want to go to a place where it's 70% or 0%. So, you know, that points to a problem, I think, in terms of, you know, obviously documentation and then understanding what it means and what the implications are for care. So, I think that slide is going to justify maybe a follow-up study and to do some more of these qualitative analyses that we're already talking about. The people who got DNR orders in the VA look like the people who get DNR orders in many other studies. So they're obviously older, they're more likely to be white, meaning actually that African Americans are substantially less likely to have DNR orders documented. They have higher stroke severity, they have higher comorbidities, they have a higher Charlson score, they have the higher Apache score. Apache is that acute severity index score, so they come in sicker. They have higher rates of in-hospital complications, atrial fib, AMI, pneumonia. They're more likely to come from an extended care facility nursing home, not surprisingly, and they're more likely to be admitted to smaller hospitals. In this data, smaller hospitals again documented higher levels of DNR, which is again previously been reported. So these are just some slides we'll just flash through. So this is the overall prevalence of DNR orders in the data, 13.5%. So these are row percentages that should be compared to. So this slide shows nicely that, as you'd expect, DNR orders go up with age pretty dramatically. They're low in African Americans compared to whites, and they're higher in patients, particularly those that have the most severe stroke, NIH score greater than 10, 36% DNR order prevalence. And then these are comorbidities, so pointing a few out, higher in dementia patients, and higher in any cancer patients. So, you know, some of this makes sense. There's good face to validity to some of this data. Higher in patients who have atrial fib. Patients who had in-hospital complications of atrial fib had higher prevalence, as did acute MI patients and pneumonia patients, and then 42% of the patients who came in for a nursing home or extended care facility had DNR. So this is all pretty much what you'd expect to see. And again, the smaller hospitals, the lower complexity hospitals, have a higher DNR prevalence of documentation at least. So, what did we find in terms of the relationship between DNR then and quality of care? In our unadjusted analysis, DNR patients were significantly less likely to get TPA treatment. Hardly anybody got TPA in this whole data set. So, they were less likely to have stroke severity documented. They were less likely to be early ambulatory by hospital day 2. They were less likely to be on cholesterol treatment and to have stroke education at discharge. But for some reason were significantly more likely to receive full risk assessment. These data here are just showing the differences. So of the DNR orders group, 20% had NIH stroke scale documented compared to 26%. That's the difference there. Early ambulation, 72% of the DNR patients were early ambulatory compared to 85% of those without DNR. So those are some of the unadjusted relationships. And there's the lipid, less likely to be discharged on lipids, and a lot less likely to be educated on stroke, although nobody really got much stroke education in this group, in this project. So that was the unadjusted relationship. What happens when you adjust then for age, race, stroke severity, Carlson score, pre-stroke ambulatory status, looking at the relationship between DNR status and quality, compliance with these quality indicators. Really the only variable that consistently showed was that patients with DNR were less likely to be ambulatory at 2 days. Odds ratio 0.58 for DNR compared to no DNR, and it didn't really make much of a difference when DNR factors were documented, whether it was the first day or 2 or more days afterwards. We also found some signal with early antithrombotic use by 2 days being less likely in patients who have DNR at 2 days, and also assessment for pressure ulcers were a little lower, odds ratio 0.63. But we looked at a lot, this table, we looked at a lot of associations, so you have to worry about some type 1 errors, multiple comparison problem, but the consistent finding was early ambulation. So I guess the bottom line is there wasn't a lot of association between DNR and these particular performance measures, which was sort of good news to the VA, and really is what the message is on this paper that hopefully is going to be coming out. Just to mention about what is the impact of these CMOs, remember we talked about them being excluded from the denominator. What happens when you put them back in? The bottom line is not a lot. It really doesn't change the performance, mostly because there's only 4% of these people. So 4% don't really impact a lot of things. And so they really had a minimal impact in the end of the day. In this particular case, it did not affect the overall compliance. Just a quick look at mortality. These data are, they're surprising by just the magnitude of the association. Obviously, nobody walked in here thinking that DNR was not associated with bad outcomes, but just the magnitude of this is sort of surprising even to me. So we knew that overall in the whole patient population, 193 patients either died or were discharged to hospice. That's a 5% rate, 4.9%. Of these 193 patients who had a bad outcome, 82% had a DNR. So going back to my first one of my earlier comments, that most patients with bad outcomes have DNR. And in this patient population, 58% also had comfort measures only. So these things are common in people who have bad outcomes. So 29% of the 535 subjects with DNR died or were discharged from hospice. Here, that's 27%, compared to only 1% of the no DNR patients. So, if you want to walk out of the hospital, don't get DNR, because chances are you're going to do okay. Or try to avoid it. That's an odds ratio of 37. Okay, not often you see odds ratios of that magnitude. So obviously a big association between DNR and poor outcome. We also looked at the timing of the DNR, so this is splitting DNR now out into whether you basically came in or was documented within the day of admission versus 2 or more days. We get some stretching of that odds ratio, so now we get an odds ratio of 78 if you had a DNR documented after 2 days versus no DNR, and 26 if it was documented on the first day compared to no DNR. And comparing a 2-day DNR to a 1-day DNR still results in an odds ratio of 3.0. So again, delayed DNR is a poor prognostic sign, as we would expect. And then, so what's the impact of the CMO within patients who already have a DNR? Well, in this patient population, CMO, as we would expect in this framework or this data, had a marked impact on outcomes, on bad outcomes. So this is just among the 535 patients who had DNR, and this is amongst those who were either the 139 who had CMO, and the 396 who did not have CMO. And the mortality rate in the CMO group was 78% compared to only 12% amongst the DNR patients without CMO, odds ratio of 25. So CMO has a huge impact even amongst the DNR patients.
Just for clarification, CMO to me means you don't give antibiotics for an infection. This is clarifying the point that were made before. Did you look at anything such as an obvious thing like that would differentiate DNR from CMO?
Right, so we don't, it's a good point, we'll get to that towards the end. We don't know what the true definitions or what the implications are of CMO. And unfortunately, all of that data are abstracted. We do not have a variable that says, antibiotic use for whatever, whether it was pneumonia or complication. So we'll get at that, but we don't know. Bottom line with these data, we don't know the context that these orders were placed. We don't know what the interpretation is of these orders necessarily, and how they vary across hospitals, and then how they really impacted the life-saving treatments that can result in this.
A decade or more ago, John Sten, running the ethics committee, agonized forever on the difference between DNR and CMO, and so I thought that some substance would have come.
Yeah, I mean, again, the CMO is just like, did you label any one of those terms? And then again, what's the implications of that? The implications are, as should happen amongst DNR patients, that the CMO does mean something. It obviously means something very significant. So if you're DNR and you don't have CMO, your prognosis is obviously a lot better. But I think it points to the fact that we need to be documenting both of these things and have a better understanding of what they mean.
It's a small point, but you're at a range there where the odds ratio isn't really a good estimator of the relative risk, aren't you?
Right.
And it's more than a straight methodological issue, because I think that's like a relative risk of maybe 6 rather than an odds ratio of 25.
Right.
So
no, you're right. The odds ratio, that's a good point. It's good for a dramatic effect, but you're right. When the outcomes are not rare, and these are common outcomes, the odds ratio is a poor measure of underlying relative risk. Yeah, well said. Just to wrap up here then, and we've really had to be careful in terms of how we phrase these conclusions. The reviewers have raked us over the coals for maybe going beyond what the data say. But we now phrase it amongst these carefully selected quality indicators. These findings suggest that veterans with ischemic stroke who had DNR orders were not treated differently from other veterans with stroke. However, whether these health professionals inappropriately extrapolated DNR orders, or maybe they appropriately extrapolated DNR orders, depending on your perspective, to other potentially life-saving treatments, as we've mentioned, intensive care, feeding tubes, antibiotics, hospital transfers to specialty centres, we don't know. But some of this data is not available in this data set. Some of it is, and I think now we have a good reason to go back and start. And once this sort of good news paper is out, we can really start looking at some of the dirty laundry, perhaps amongst the data. So that remains to be determined. The prevalence of DNR orders, 13%, was a little lower than previously reported. In stroke patients, 21 to 34%. This probably reflects the fact that we don't include hemorrhagic strokes, which are obviously going to have a higher DNR order. Our spectrum of stroke severity was really quite mild in this patient population. And our in-hospital mortality rate was, again, lower than what's been previously reported for stroke patients with DNR. These reports were back in the 1990s. Again, this is probably due to a later time. 2007 is a lot different from the 1990s in terms of improvement in outcomes. We now have shorter length of stays, which is obviously a big predictor of in-hospital mortality. And again, this issue that the prior studies did not really make a distinction between DNR and CMO and these other measures of palliative care. So I don't really think the previous studies are actually comparable to what we've done, because now we're trying to make a distinction between the two. And And so we did not collect data that would help explain the clinical context in which the DNR orders were placed. You know, there's a huge difference between advanced directive versus treatment failure. There's substantial variations we saw across hospitals in the documentation. And of course, we always have to worry about generalization of the VA data to non-VA sites. And again, already covered, we need to look at these potentially life-sustaining treatments to the extent that they are adequately documented in the data. And we have not really determined the independent effects of DNR orders on mortality. I showed you those crude odds ratios. We did run some early adjusted analyses, and you can't make those odds ratios go away. I mean, if you're starting off with an odds ratio of 37, you know, you're not taking it down to 1. You know, I can get it down to 8 or maybe 6, but you know, still a huge effect. And I don't really know that you can ever really control for the you can't control for that residual confounding. There's so much more context we really need. So we've decided not to do that. And then, so what do we need? Future studies. Well, there's a lot to be studied. I think we need to understand what are the hospital policies that can contribute to that wide variability in documentation. What are the policies and practices related to the quality of DNR-related discussions? So there's several editorials talking about how hospitals, physicians should engage patients and have these discussions about documentation and really what that means. And obviously, if there's this much variability in the documentation of DNR, there's probably even more variability in exactly what that DNR means to people. Question the reviewers asked, does the effect of DNR orders on the quality differ between hospitals? So maybe DNR doesn't have an effect overall, but maybe there are some hospitals where it really does have an effect. The problem in this data is that the documentation was so poor, and we have so many sort of hospitals with 0 DNRs, that it's actually difficult to look at the impact of DNR across different hospitals. But I think it's something that should be done. We obviously need to understand the clinical context of these orders, and we need to determine the impact of DNR orders on these full range of these life-sustaining treatments. So yeah, so lots of work to be done, and I still find it amazing that in 2012 we all recognise the terms DNR, but we can't seem to figure out what it means, which is you know, I think really interesting. So I'd be interested to know how is DNR handled here in Ontario, or how does anybody handle DNR in their analyses of quality and outcomes? Thanks.
All right. We've got time for questions, although we won't go all the way to 1 o'clock. Mike, are you first? And then Merrick.
So I think it's really interesting work, and I think I mean, I don't know how you could do it here unless you were going right into the charts, the paper charts, and looking for these orders. I don't think they're documented well. But I want to take a different spin on your results. You showed basically that having a DNR order was not associated with worse quality. Essentially, the quality outcomes were the same. And I would take the opposite tack. I would say if you look at the quality measures that you presented, which were developed for all stroke patients, I think the patient population, which is DNR CNO, is a completely different patient population from the overall stroke population. And that if you were to get a bunch of experts around the table to think about quality measures for those patients, they would look very different from the ones you did. So I would say if the DNR patients are having as many CT scans and as much thrombolysis and as often getting aspirin and so on, that to me suggests they're getting worse care. That they're getting inappropriate tests, inappropriate treatments they shouldn't be getting, and maybe not getting the care they should. We don't know that because those. But I don't find it comforting that the DNR patients are getting exactly the same care if that's what your results show. Yeah. I would actually see that as a sign of concern that they may be getting poor quality care, at least care that's not really focused on what they need at that stage of their life or what their caregivers would prefer. So I just put that out and see what your thoughts are.
Yeah, so I think when you extend it to the CMO patients, that clearly CMO, when you document that, you know, that's an indicator that you should not be delivering all the care that is needed. I mean, again, it goes back to your definition of DNR. If you take a strict definition of DNR, which is saying, like, if I have a cardiopulmonary arrest, I don't want the paddles and be intubated, then I guess it's a philosophical. Well, it should be more than a philosophical debate. It should be. We should know what the policies are and what that really means. And the fact that we struggle amongst ourselves to kind of articulate what that means tells me that what should DNR mean? And your interpretation is broad. I think your interpretation is practical on what really goes on, quote unquote, out there. But the strict quality outcomes definition is what was shown, which is that is the only limitation that should be placed on that patient, and that's been the drift of a lot of the publications on the DNR to saying it should only do that, and therefore we should not see these other differences in quality. But I obviously get where you're coming from. Yeah.
Okay, Merrick, I think you were next.
So, if I understand it correctly, what your study says is that patients with DNR have a similar amount of life-saving and other treatment than patients without a DNR, but still their mortality is very much higher. And I think I understand your question to be, is it the presence of a DNR which is causing the absence of other life-saving treatment that results in this high mortality? Is that a correct understanding?
Yeah, that's what...
What about another explanation which would go something like the presence of a DNR is an indication of other morbidity that may be mortality causing, but which is not captured in the Charlson or the severity of stroke or some other things. And the one sort of obvious one that I'm thinking of is dementia. So if these patients are coming in with dementia, I'm not sure how well captured that or other predictors of mortality are by the indicators you have for morbidity. So, and then the consequence of that would be, sure, the DNR captures severe morbidity, which may predict mortality, and that's why these patients die more. It's got nothing to do with treatment, which you've already shown is more or less equal.
Yeah. Yeah, no, I think that seems a reasonable interpretation of data. So the basic, quality indicators that we care about in stroke were delivered equally. You've got this big increase in mortality, which is not unexpected. And the question is, do you want to get into the data to try and figure out whether there's inappropriate? Well, we can't even agree we can't necessarily even agree what the difference between appropriate and inappropriate is. But are these DNR orders being used beyond their original intent or original definition? And that requires us to get some more of those life-saving quality measures and look at that. And I agree with you that we shouldn't. That the increase in risk with DNR is probably mostly because of what we call residual confounding, that they've got so many other comorbidities and factors that are causing them to have poor mortality. That's what's driving it. It's not necessarily inappropriate withdrawal of care, but we don't know that yet.
If I may just make one, I wouldn't call that residual confounding. I would call that patient-centered care. That's why the patient has a DNR. It's not an epidemiological problem with the data. There's a very large red flag there that the patient or their family have put in place, asking for a certain attitude to care. The precise meaning of that attitude to care, we physicians may not agree amongst ourselves what that is, but there's a really big flag there. Don't do too much.
Too much, yeah. But then,
why not take your explanation down that part?
Yeah. Do we have an obligation to figure out, in these specific quality studies, is there an obligation to figure that what that range of interpretation of those measures are, about what, is it important to document how that particular order was interpreted? Maybe
which I think David spoke to the need for qualitative work to understand.
Yeah, I think that's the place to go next.
Okay, and on that note,
Right.
Willen?
Thank you.